Bueno, muchas gracias, Tony. La verdad es que es inusual, por no decir casi único, que haya un antropólogo médico en un ensayo clínico aleatorizado y controlado, porque pues, la antropología se considera una especie de ciencia menor, si es que se considera ciencia, frente a la biomedicina, que es el gran monstruo hegemónico que lo domina todo, ¿no? Entonces, poder tener esta perspectiva etnográfica en un ensayo clínico creo que lo ha hecho sumamente enriquecedor. Así que muchas gracias también por la presentación. Y ahora voy a presentar a Lorena Terene. Lorena es bióloga, trabaja en el laboratorio de Rafael Guimaraes. Ahora está en Maastricht haciendo una estancia predoctoral, está haciendo su tesis doctoral y con un ensayo clínico precisamente con ayahuasca en el tratamiento del trastorno de estrés postraumático. También algo novedoso. Desde hace muchos años hay muchos modelos teóricos que vienen explicando que la ayahuasca podría ser de utilidad para el tratamiento del trastorno de estrés postraumático, pero en realidad la evidencia era mínima o nula, y menos una evidencia proveniente de estudios controlados. Y esto es algo que Lorena pues, ha empezado a hacer y que nos va a presentar hoy. Gracias, Lorena. Adelante.
Hello, as he said, I'm Lorena. I'm a PhD candidate at the Universidade de São Paulo. And today I'm going to present a little bit about my PhD project investigating ayahuasca as a treatment for the PTSD disorder. Can you? So PTSD is a disorder that can develop from the exposure to one or multiple different traumatic events. And this exposure can be direct, like the person experienced the trauma, or she or he witnessed the trauma from another person. So the main causes of PTSD are especially sexual and interpersonal violence. There are also exposure to organizational trauma, natural disasters, war. We see a lot of studies focusing on war veterans, but the main cause is usually sexual violence. So apart from the first criteria, that is the traumatic exposure, there's other criteria to diagnose PTSD, and they include the re-experiencing of the traumatic events, and these can happen as intrusive memories, nightmare, flashbacks. They also present avoidance of trauma-related stimulus after the trauma, so they will avoid things that remember them, the traumatic experiences, places, people, and often will result in changes in the behaviors of the person. Also negative thoughts and feelings that can begin or worsen after the trauma, and this can means that they can have exposures of like anger or also a lot of guilt. Many patients feel guilty about the traumatic events. And also enhanced arousal, hyperarousal. That can also mean increased irritability and decrease in emotional control. On top of that, many symptoms that can impact drastically on the life quality of patients. PTSD patients have 80% more chance of presenting other mental disorders. It's very frequent that we see these patients also having problems with anxiety, depression, substance use disorder, and increase on impulsivity behaviors that can even lead to other diseases like diabetes and obesity. Okay, the next one. Specifically talking about Brazil, that's where we are doing the trial for my PhD. The general prevalence is not that high. It's usually lower in underdeveloped countries than in first world countries. We have less than 2% prevalence in São Paulo. This study investigated the prevalence in the metropolitan area of São Paulo, but it's much more prevalent among women than men. I think considering that sexual violence, it's the main cause the main traumatic event that can lead to PTSD, that explains a lot. And the current treatments, and I'm talking about pharmacological treatments, are SSRIs, so antidepressants, but they are not effective for most of the patients, over like a half of them. And also they don't treat the main cause. They will treat the anxiety, maybe help with the emotional control, but they are not treating the traumatic experience, the trauma itself. So from that, there's this theory about the psychedelics, and up to now, there's not a lot of work, apart from MDMA, on clinical trials on the effects of psychedelics for treating PTSD. With ayahuasca itself, you can find case series and case reports, especially with war veterans. I brought this one from 2023 with war veterans that went to Costa Rica to ayahuasca retreat, where they received 3 doses. And after the 3 doses, 7 out of 8 participants reported an improvement in the symptoms, and they follow up until 3 months after the retreats, and from these 8 participants, 5 of them still had like an improvement 3 months after the treatment. And they measure this through the post-traumatic checklist scale. It's an instrument to evaluate PTSD symptoms that we also use in our work, and I will present the results later. But this is, up until now, the main type of evidence that we have for ayahuasca itself. But apart from ayahuasca, in our studies in the lab in Brazil, the Fantástica lab, we also investigate ketamine as a potential treatment for mental disorders. About ketamine, we have more evidence in the literature, also very small trials, but here I brought an example, again, with war veterans, because most of the studies are developed by North countries where they have wars. In Brazil, it's not exactly the case. And here, they administered intravenous ketamine 3 times a week for 2 weeks, and they also saw an improvement in the symptoms measured with the same scale, the post-traumatic stress checklist. And specifically for our trial in Brazil, we are comparing ayahuasca and ketamine, both administered orally. So most studies regarding ketamine that you find in the literature, we will use the IV, or in the case of the Spravato, intranasal. But here we use it as they drink it, it's oral. Our goal is having 14 participants in the final sample. They will be randomized into one of the 2 groups. The ayahuasca dose is 1 milliliter of ayahuasca brew that is not altered, is not in capsules. They will drink as it is, as it comes to us from the churches that we receive. And the ketamine also they drink. For my study specifically, as is the first one with psychedelics, we give only 1 dose. And the participants, after being screened by the psychiatrist in our group, because as you say, I'm a biologist, I cannot do that, but we have the psychiatrists that confirm the diagnosis. They are included in the study and randomized, and in the first day, they will receive 1 dose of either ayahuasca or ketamine. The administration happens in the lab, and we do not do psychedelic assisted therapy. We do not do therapy. They receive the dose. We are there for emotional support, to like give companion to the patients, but we do not perform therapy. After the first day, where they intake the substance, they will return to the lab 3 times, once a week, for the follow-ups. No more doses, only the questionnaires and the collecting of data. Up until now, we have 6 participants. You will see that none of my graphs are separated by drug, because I don't know who took what yet. The blinding is still on. But what we can see, regarding of, like, independent of each drug, is that after 21 days, all of our participants improved the PTSD symptoms. Most of them even cannot cut the score for PTSD diagnosed from this checklist anymore. On top of the PTSD symptoms that we measure on the PCL-5, the post-traumatic checklist, we also evaluate anxiety symptoms, and where this is being presented on the first by is the back anxiety inventory, and we also measure depressant symptoms in the one in the below, PHQ-9. The thing is, although it's very common that they have depression and anxiety, some of my participants did not have it, but still in the ones that had very high symptoms, we can see also an improvement in the mean. So I presented here the volunteers individually, but also if you look for the gray dashed, is it traçado? Dashed line is the mean. So we can see that in general they all have a decrease on the symptoms 21 days after the protocol. One thing that is I need to mention, it's in the sample, all of my volunteers, all of the patients are women, and although not all of them have the PTSD diagnosed, like the trauma, initial trauma from sexual abuse or domestic violence, although not all of them develop PTSD because of it. From the 6, 5 of them have a history of sexual or domestic abuse, what is, for me, very prominent. With all these people that I've been screening for the study, it's very common that people, even those that develop PTSD for other reasons, have this other history of violence. That's it. I would like to thank all of my colleagues. Professor Jose Carlos is always on our acknowledgements. Yes. And I would like to thank my team in Brazil, my colleagues, that also I wouldn't be able to do this until now. And, well, I hope for the next few months I'll be able to increase my sample. Thank you. And this is my email also.